Good morning, everybody. Georgia summers, am I right, guys? Also, military life, am I right? I always like to tell people that if you are fully prepared to be wildly unprepared, you will do just fine in the military. Case in point, if you read your program, you might be seeing the name Dr. Jessica Strong to be moderating this panel. She is the Director of Applied Research at Blue Star Families. She got caught in these dang summer storms. And, as luck would have it, we just PCS'd back here a couple weeks ago, so you get me. My name is Beth Conlin. I am a military spouse employment advocate. I used to work for Blue Star Families. I now work for Amazon. So please, if something strikes you, raise your hand. If you have a question, speak up. We want to help answer your questions, or we want to help entertain your solutions. We are going to start with some of these experts up here talking about the past, present, and the future of military service. But I want to start with why we're here and why we're having this conversation. You've heard that we are in a recruiting crisis and a retention crisis. And part of that is because the ecosystem of support that was created for military families just hasn't kept up. This is not DoD's fault alone. 50 years ago, when we transitioned to an all-volunteer force, every person in America knew someone who served. And that's not the case anymore. When you have that close connection to service, you step up your community, your church, your volunteer groups, your sororities, your fraternity groups, your hobby groups. You become that ecosystem of support because you can relate to the service of that military family. And sadly, that's not the case anymore. Part of that military-civilian divide, as it's called, has resulted in currently serving families suggesting military service by 10% less than they did just 5 years ago. So 2016, Blue Star Family says that 23% of active duty families were recommending military service to young people. This year, only 11% of currently serving families would recommend military service. And again, that's not DoD's fault alone. This is all about the ecosystem of support that's around us. We know that constant relocations and lack of access to childcare are struggles for military families. We know that DoD pay just isn't as competitive as private sector pay. But we also know that there's some great things about military life. Am I right? Yeah, I already said it. I'm going to say it again because it's going to be a theme of like everything we say. The military spouse community is hands down the best thing I ever got for marrying my husband. I mean, like, he's great, like, he's fine. But like, the military spouse community is the best thing that has come from military life just because of who we are and like how we approach things and how we tackle life. So there are a lot of great things that I don't want to be overshadowed, but there's challenges that we have in front of us. We want to talk about what those challenges, how they've evolved in the past and solutions that we've brought forward. We want to talk about currently, what are we working on? What policies are out there? What new implementations do we need to be aware of? And then we want to look to the front and say, in the future, what do we need 10 years from now to continue to be the greatest military on earth? So I'm going to have my panelists introduce themselves as they answer questions, because you also may notice that what you have in your program is not what you see up here because, again, Georgia summers. Am I right? So we've got some substitutions filling in for us, but we've got expertise across the board. And again, please raise your hand if you have a question or if you have something you want to contribute to that. So for my panelists, if you would, we're going to talk first about the past. We're going to look back before we look forward. Before each of you provides an answer, could you please just give a brief, your name, who you are, what you do, all those great things. So in the past, like maybe the past year, what would you say, from your point of view, has been the biggest achievement in the ecosystem supporting our military families? Ma'am.
Okay, so first, I'm going to stand to fight over, that lie, I'm like, full burn. Turn your mind up. Full. If it's okay, I'll still stand because I can't see you all, and I would like to be able to do that. So first, good morning. I'm Lieutenant General Toledo Crosslands. I'm waving the mic. How about now? All right. So thank you for the opportunity to be here today. I'm the Director of the Defense Health Agency. What that translates into, I'm responsible for running the healthcare system for the Department of Defense. So that's your TRICARE benefit inside of MTS, our hospitals, the clinics on bases around the world, as well as the benefits that you get when you're a retiree and a family member and you're getting care on the network. What an honor to be here today. Some of the comments just reminded me I have a unique perspective, perhaps. first as a soldier, as a mom, as a widower. And thank you all for your advocacy, what you do for service members. It was truly appreciated. And I want to say that there's definitely more work to do, but I am grateful that you all represent the village that wraps around our military service members and make our lives better. And you're honoring that, so thank you. The second, I get to play a role inside of the support team system as both a physician, having served 23 years inside of the healthcare system, and now is leading a Defense Health Agency. And so to the question, looking back, what would I highlight? First, I would highlight that we have a phenomenal healthcare system. We really, really do. And during the strain of COVID, we saw it rise and shine in very key areas, whether we support the nation for taking care of patients inside of our MTFs. But there's definitely more work to do. I want to first thank our congressional leadership, both the House and the Senate. You see that in the NDA, there was a moratorium on military reductions for the medical force structure. And that just underscores the commitment both within the department and for our Congress to that. So that would be one. The second is as our Secretary of Defense and our chairman of the Joint Chief of Staff the Secretary has a Taking Care of People initiative that he's pretty serious about. And they have charged me as a director of DHA to look really hard at how we can improve and evolve our healthcare system to not only be more responsive today, but also so that we position our healthcare system, and as Chief Bass said, to be relevant 5 to 10 years from now, because we acknowledge the benefit, we acknowledge our privilege to serve, and we're committed to doing that. And so those would be two things that I would highlight.
And it's important to note in Blue Star Families research, one of the reasons that currently serving families would recommend service to a young person is because of healthcare. So thank you for that, sir.
Good morning, everybody. I am Major General Roy Mackerick. I am the Senior Military Advisor for Assistant Secretary of the Army Manpower Reserve Affairs. In my portfolio, I got training, readiness, mobilization on one end, and on the other end, I'm also the Director for Quality of Life. What we do in ASAM&RA is to provide oversight in a lot of the policies in the Army, working, collaborating with OSD, DNR, working with the G9, Mr. Clipstein, who actually does all the work. Excited to be here, excited for the conversation. And we are here to listen to what, ideas you have to make sure we provide that quality of life for our military families. I would like to thank Congressman Bishop and Congresswoman Rogers for co-chairing this since 2009. Very impressive. Thank you for your commitment to the military families. So looking for the conversation, again, thank you for having us. To answer your question, in the last year, again, from the top down, Secretary of Defense, all the way down to, Army senior leaders and all the things we do in the Pentagon, we have had so much effort in making sure we provide a quality of life for the military families. Taking care of people. If you look at all the senior leaders' priorities, it's all about taking care of people. And throughout the day, we're going to have this conversation and looking again forward to the conversation. So, thank you.
Hey, good morning, everybody. I'm Dan Clipstein. I'm the Assistant Deputy Chief of Staff, G9, and I want to say thank you to the Blue Star Family group for hosting this. To the congressional support that we get for this, and for the support from all of you for what you provide to our Army. Briefly, the G9 is really the responsible agent for installation, but it's also grown to become a significant focus on quality of life, family programs, resilience. We have $18 billion of the Army's budget invested in our installations. And that's everything from housing to military construction to barracks to base operating services that you look at on installations every day. I look at the Joan Buzzard and I look around, and you when you think about what happens on installation and an installation commander, those resources support installations and families and services that are out there. And we try hard to put that money to good use by distributing it out and allocating it to the places where it has the greatest effect. I'm a soldier for life. I spent 30 years of active duty. My wife is a military brat. She was born here at Martin Army Hospital. My youngest daughter was also born here. So I have a kinship to this area, and they share and I share the same effects that you all see every day from life in military service. And so, thank you for all you do every day. I remind our folks when I'm in the G9, and I remind them for things that we do, actions large and small that take place on the Army staff. And while that's distant for many people, it has an effect on what we do, on what happens on installations. And so I remind them every time I get a chance that actions large and small, I can draw a direct line from the things that we do on the Army staff to an outcome on an installation. And that's pretty much through the effect of policies, operational directives, and resource distribution to enable systems and programs to help you. To really answer your question that was asked about, what is one of the biggest achievements, I would tell you it's not visible to most folks, but we have a quality of life task force that was established about 2 years ago by the chief and the secretary. And this task force works across the Army enterprise to address issues that affect everyday life. And there are really 6 areas that we focus on. Housing, and that's both privatized housing, Army housing, and barracks. The health care that we provide, that is provided to all service members and families. Child care, big emphasis on what we're going through there, and glad to answer questions on that. Spouse employment, PCS moves. We all moved multiple times, and that the things that we've done to try to improve that experience for families and for service members as they move from location to location. And lastly, a focus on supporting soldiers and families in austere and remote locations. And you can think Alaska, you can think Fort Johnson down at Fort Polk, Fort Irwin. These are places that are a little bit more distant and remote. So we spent a lot of time working on improving the quality of life for them as well. So that task force sits at the Army level. It's not necessarily always visible, but I will guarantee you that the chief and the secretary get briefed every quarter on the things that we're doing and how we're supporting and enabling outcomes on installations.
Thank you. Just to follow up on a few things that you brought up, for folks that I know you're sort of like conjuring up the courage to ask a question, a couple of data points to keep in mind that might help formulate a question for you. Blue Star Family cited that last year during PCS season, the average family spent quite a bit of money out of pocket for their PCS. Any guesses on the average amount? 10 grand, close. 1,500, how I wish. That is like a pipe dream, sir. $8,000 out of pocket costs military families are spending on average for PCS. Sure, there's lots to talk about around that. The other thing that Blue Star Families has cited around military spouse employment and the challenges associated with that is childcare, not just lack of access to it, but the affordability of it. So I had small conversations last night with a few folks that were here to reception. They had some I think, decent solutions or ideas around the childcare situation. So if you are living in that and you see a solution in front of you, you have the people here to help push those solutions forward. So please don't be afraid to speak up. Ma'am.
Oh, good morning. My name is Erica Slayton, and I am here representing our Deputy Assistant Secretary of Defense, Mrs. Patricia Barron. She was not able to make it because of the weather, but certainly so happy and pleased to be a part of this conversation. I'm the spouse of a retired Marine, so I may be in the minority here and already. Thank you very much appreciated. Mrs. Barron, if she were here, she would definitely speak to the fact that she was an Army spouse for 30 years, and so military family programs and services just with the heart of what she does, and who she is, and her passion pours through in everything that we do within military community and family policy. So again, just really happy to just continue the conversation, but not only continue the conversation, but work towards solutions with all of you here at the room. We talk about the biggest challenges, and you said it, that we're talking about spouse employment, child care. So if we're looking at some of the biggest accomplishments over the past year or so, I really think it dovetails to the heart of taking care of people, as we've already said. And one of the items I really like to talk about is childcare and the unique needs that our military families face in terms of childcare. So one of the programs that we always like to highlight is the military childcare in your neighborhood, and that is the Department of Defense's child care fee assistance program for military families who use civilian providers in the local community. We've done a lot of work in this area and have an additional initiative that expands upon the military child care in your neighborhood, or an MCCYN Plus initiative. And again, it expands it. And this is designed to recognize child care providers who are enrolled in their state's child care quality improvement program. It is we have done a lot of work around this to expand it to 9 states, and we're looking forward to, at the end of this year, expanding it to 15 states. So we're really excited about all of the accomplishments within the child care space. The other part of the child care piece that I'd like to hone in on is the child care in a home fee assistance. We've expanded that, and the program currently is in year 2 of a 5-year pilot. And this provides fee assistance for full-time in-home child care providers. This pilot has extended from 5 locations to 11 locations, and again, just really excited about the opportunity. It now includes lawful permanent residents and family members who are eligible for in-home providers, or as eligible for in-home providers. And then the second piece of it, because you can't talk about child care without talking about spouse employment, is what, through the Department of Defense, we offer the Spouse Education and Career Opportunities Program. And through that program, we have several initiatives. One is our Military Spouse Career Military Spouse Career Accelerator Pilot, or MSCAP. You have to have an acronym for everything, so I'm always getting tripped up on acronyms. But this was an opportunity for the Department of Defense to provide 12-week paid fellowships for military spouses. And the goal of the fellowship is to turn from fellowship to employed. We did a soft launch in December, and it was overwhelmingly positive, received a lot of participation. And in January, we started placing our first spouses. We have placed over 100 spouses in fellowships who have gone on from fellowships to employed. These spouses who have gone on to employed have an average salary of $77,000. And again, just really excited about all of the accomplishments within the military spouse space. And then the second piece I'll talk about is the My Career Advancement Account. And this past March, we launched an expansion of My CAA, which is a $4,000 scholarship for military spouses, eligible military spouses in pursuit of a license, certification, and associate's degree. And this helps them to become more competitive in the market. We expanded the program to include spouses, the spouses of service members who are active duty in grades E1 to now E6, O1 to O3, and then W1 to W2. So again, just really excited about all of the opportunities in the child care and spouse employment space, and looking forward to continuing the conversation here.
Quick pulse check from the audience. Raise your hand if you were aware of the military child care assistance in your neighborhood. Okay, so like 7 of you. Okay, all right. Raise your hand if you were aware of the fee assistance for full-time in-home providers. Okay. What about the MySECO career programs? All right, and what about the MyCAA advancement? Okay. All right, so what I'm hearing is DoD, obviously not a marketing company, we are not doing a great job of getting the word out, because those are some really, truly amazing programs that hit right at the pain points that we're all facing. So I have a feeling this will spark some good conversation. And now that you've heard this great news, you, Lucky, you get to pay it forward and share with everybody so we can help market this for them. Ma'am, what do you think has been the biggest changes in the last year?
All right. Good morning. Thank you. I am Chief Master Sergeant Robertson from the Air Reserve Personnel Center. I am here to represent the Air Force Reserve Command. And within this, I would just like to say thank you very much for the invite to sit on this panel, and while my esteemed colleagues sit in amazing positions with the ability to do an awful lot of things, the Reserve Command is here, and quite often the silent support behind an awful lot of things. We are your citizen airmen who live locally and serve globally. And what that means, if you're not familiar with the Reserve, is quite often we are in your communities. We are your police officers, we're your firemen. We are your school teachers, everything in between. And then on the Reserve weekend, we are your military force that comes in and supports. With that, we have an awful lot of opportunities to be a part of community support systems and benches. And we oftentimes find ourselves advocating singly and solely for the military piece. There's some benefits to being the citizen airman that we also need your support in. And those community support structures that we talked about, the child care support structures, that being able to license our civilian force to help us with that child care. An awful lot of them absolutely don't even know what those opportunities are out there as community members and being able to help the military. So I would say that one of the biggest, best things that has supported us lately is the licensure reciprocity. We face that quite often in the Reserve Command when we do PCS. A lot of people think that as a reservist, you stay local the entire time. We have a growing force of AGRs, which are the active guard reserve components of our force. And with that, we face the PCS pieces, the child care issues, all of those things also, just not on the global structure that the active duty faces. But within that, the licensure reciprocity has made such a difference to us. We would really look forward to, and everything can always be a touch better. There is an expansion to the Military Spouse Licensing Relief Act to reserve spouses. And one of those opportunities would be for our Air Reserve technicians. So that is, we are civil service Monday through Friday, and it's tied to our military position. What that means is we still move in PCS in a civilian capacity. However, it is tied to our military position. So if we would have an expansion to that benefit, that would help just one more piece of that licensure reciprocity, because as it stands right now, it only benefits the active duty. So that would definitely help the Reserve Command. It's a great thing that we have it where we do right now. A little tweak would be great. Thank you.
Thank you. How aware were folks of the executive order around military spouse licensing reciprocity? Folks familiar? More familiar? Okay, so like the White House does better at getting the word out than DOD, noted. But just if you're not aware, there were some compacts with certain professions, nurses, teachers, that the associations among themselves sort of got together and through the states sort of said, I'll accept your license if you accept mine. That didn't exist holistically across the nation, nor did it exist for every licensed profession. With the executive order that President Biden signed, I think in like March-ish, it is a mandate, but it doesn't stop there. It's up to the states to implement it. So any state leaders here, any folks who are residents of other states other than Georgia, this is when you can use your voice to talk to your state legislators, to encourage them. You want to talk to the Secretary of State of your state to encourage them to get this legislation implemented. There are tons of states that have great examples. Colorado, their website is kind of idiot-proof. Even a Marine could do it. Super helpful. I will call it to see it. Florida's website, also super crystal clear. It's just about military spouse license transferring. Utah's website, crystal clear. So if you need an example to take to your state legislators, those 3 states have really good examples, and you can just take it and say, do more of this, right? Okay.
Georgia, where?
Georgia, yeah. Georgia's already doing the things, right? Right? Yeah, totally. Okay. So that we just took kind of a look back and said, what have we done? What accomplishments have we had in the past year? I want to talk now about the present. But before we do that, based on what you've heard from our panelists up here. Are there any questions or things that you would like to bring forward? Yes, ma'am.
I know that the DHA are still foxy that speaks to resigning and their young tier. There's a lot of change in state place. I'm retired, my husband's retired, and we're thinking it in the next 10 years, a significant cost increase as you transition from Tricare to Medicare and Tricare for life. I mean, it's not just double, it's about 5 times what the UK, and it's including fully preserved Medicare food grade. It kind of throws the 1966 AVAA out the window. So we need to know a little bit, one, about communicating that to the retiree community, and two, what can be expected the way of mitigating some of those costs. It's understood across America that we have 3 generations of people in the workforce because of healthcare. We have mothers, daughters, and grandmothers. And so now military retirees are looking at falling into that because at 64, we'll get the letter that says we're not necessarily able to be sitting at military treatment facility unless there's space available, and then that cost grows even more. So we need a little bit of information about that. And then number 2, I wanted the panelists to speak about expanding the retiree service office on host, because right now it kind of focuses on retirees that say retire at that point. But once you're retired, there's no budget or no outreach for those of us who have been retired for 10 years or more.
Thank you so much. Do we have anyone that can contribute to retiree healthcare and then retiree support services?
So I think I heard the question, and I'm going to rephrase and repeat it, and if I got it wrong, correct me. But I think the first question, part of your question is when you go in as a retiree, care on the installation, how is that changing or not, and in cost? Okay, I'll take the easy one first, which is cost. With respect to cost, what we pay in reimbursement and what your co-pays are is set. Most of that by legislation. The reimbursement is with Medicare, by law. Okay, and when you price out what retirees pay compared to everyone else in the world, it's pretty on the low end side of cost. I'm not sure I'm tracking the association of when you turn over 64 and there's increased costs. So you have to make me a little smart on that part of your question.
At 64, retirees still don't matter. They basically stay. Unless there's space available, we have to go seek a civilian doctor. And I'm going to kind of one at a time. At that point, then what we currently pay increases to a minimum of what the current Medicare bill rate is, I think $64. That's more than double what I pay. Then you also incur the cost of 20% of the Medicare approved rate for any specialist that you see. For someone like me, I see about 7 different specialists. Then you incur any hospital cost because you're no longer seen on military treatment facilities. For me and my husband, that comes to over $1,000 a month, way more than $1,000 a month. And so we look back at the 1966 NEAA, where it said that retirees should receive free medical and free dental, or at the very least a minimal cost. We look at that as one of our benefits, even though the rest of the world I know that it's different for retirees. So we left the military with that understanding, and now are faced within the next 10 years, creating or looking at a significant increase in what we will pay for medical care.
So I think what you're saying is when TRICARE for Life came in with all the rules you just described, you would rather see us go back or at least leverage 1966 legislation.
I would absolutely like to see that, and I would absolutely like to kind of voice in it.
All right, so I'll point that to you, so the political wills and how you work that. But what I will speak to is the caretaker on the installation. And the fact is our healthcare system is smaller than it was 20 years ago, as is our force, and I think we all see that. Our priority is to take care of service members and their families and get as many retirees as you can into our healthcare system. So what are we doing about that? I think your next question is going to lead into some of our challenges and what we're doing about that. Some of us going to jump to that.
Yeah, we can do it.
Okay, so what are we doing about that? First, we've got to stabilize our system, meaning do better with the staffing. And so I learned a lot here today as well on the reciprocity of licenses. That executive order helps quite a bit when we're hiring professionals like nurses and taking down the lead time for them to give their license in the state to work in a facility and support. Okay, that's great. We're working on decreasing the hiring time. And I've been in uniform for a minute, and I know we say that, but I promise you, you've got some pilots where we're starting to see some results. We're able to bring people on faster than 6 months when we lose them. We're getting it down. Our target and our aggressive goal is a stretch goal of 60 days. It's not a stretch goal. I think we can achieve from the time we see a need to the time we bring someone on, getting that window down to 60 days so we can increase our staffing in our NCFs. Or increase our staffing in our facilities, then we have great opportunity to take care of more of the beneficiaries, right, to include our retirees. The second part of what we're doing is if you've looked around in healthcare in the United States in general, we have a lot of medical deserts. We have a lot of locations where your experience, ma'am, I acknowledge, is valid. Not only do we put you in the network, our network teammates and partners who are working very hard to get you the care are finding that you're going to have to travel further and further. And so do we use some of the tools other systems are using, like in technology, right? So can I do part of your appointment virtual, take care of you inside of our system, and when you need higher ed acuity, work tied with the managed care support contractor to either get you into a network provider or back into one of our MTFs. You're traveling already. If I could have you travel to a military treatment facilities, you net all the benefits that you laid out. And so we're aggressively leveraging technology. When I say technology, it's not AI. We will use AI. We'll talk about that later. But it's simple being able to work with Humana and HealthNet Tiger to see everybody's requirement and then figure out how we manage your care at the personal level to get you inside. I have a digital front door initiative that will roll out this next first quarter, and that starts with looking a bit like USAA, meaning no matter what you need, if it's USAA, you start with 1-800-531-USAA. You need to make medicine that's straightforward for everybody, whether you're active and an active duty family member or you're a retiree. And once we can see you all, we'll do a much better job and have great opportunities to leverage and bring you into the MTF when we have the capacity or not, okay? I'm sorry I can't wrestle with 1966 to the TRICARE for life, but what I will say is I'll underscore the benefit and what we do for the benefit is fairly robust. There's opportunities to improve how we execute it. We must do a better job of executing your benefit at a personal level. Thank you.
Yes, ma'am.
Can I make a suggestion that you give a mic even in the audience?
Do we have other mics? Will? Party people? No? Okay. Yeah. Yep.
Yeah, there's making me see it bigger.
But hey,
Yeah, well, while we're doing that, to answer the retirement service officer question that you had, we probably need to look at that, expanding it to the capacity of it. Now, you said you're retired, so the primary audience for the RSOs are people who are actually getting out. We do acknowledge that the idea of you being a soldier for life, right? That whole idea. I had a conversation with Mark Oberfer, the director for Army Retirement, and we sat down. That's one of the things we're going to look at in terms of making sure, the idea of soldier for life, you serve, you transition, now you retire, you continue to be part of the Army family. So, we need to make sure we continue to take care of you and your family. So we're going to look at that, and if we have a time during break, I would like to have a conversation and really look at your situation.
Auntie was there. Going it.
So, General Crossan, this was for you, and I've had the pleasure of working at a military treatment facility and working in the civilian sector for medical, and I see some of the barriers that we have with getting our retirees in for appointments, our kids in for appointments. And what I was wondering is throughput metrics. I was hoping when DHA came in that is there going to be a consistency and implementation to evaluate throughput metrics, like how long arrival to triage, triage to disposition. And some of those even put into our behavioral health and our outpatient clinics. When you call to make an appointment, when's the first available appointment? Is it 1 week, 3 weeks, 6 weeks? What's that consistency so we can look through and try to find those barriers and where to put improvements. But the important part, having worked at multiple places, is that having those data definitions, where if I get treatment at Martin Army, it's going to be the same at Wynn, it's going to be the same, everywhere. And just to improve our workforce, to make sure our metrics are better. I think we have lots of improvements we can do.
Absolutely. We do have throughput metrics. We do measure your time to when you interact with the system to the time of your first appointment. We measure your acute, your routine, your specialty care. So we do have those metrics. What we don't have well and what we're working to do better is take the wins that we know work and push it across the entire system. And I think it's important I give my team grace and give context. As most of you can appreciate, the transition of the entire healthcare system occurred over the last 5 years, on par with the stand of the United States Air Force. That's how big it was. And so as we settle in, and when I talk about stabilizing the system, maybe that's exactly what I'm talking about. We know how to do certain things very well. We do have to acknowledge that healthcare is at an inflection. You're a nurse, I think there are other nurses in here. We have an ascending shortages of nurses. Next year to two, somewhere around 250,000 registered nurses would be what our shortage is. And you don't have that overnight. That means we're living the shortages today. The pandemic accelerated that, so I'm sharing that because there's some realities to, while we know what we need to do, I'm convinced that doing what we've always done will not get us to where we need to be. And so we're not going to just measure and implement things that worked in 2017 before we transition the system. We have to challenge how we deliver our care. We have to challenge and take some of the lessons we learned in the pandemic, such as many of you did a lot of your care from your home on your phones, on your computers, and it was safe and it was responsive. So if we reorient the system to the amount of care we could truly do in that space, we free up space. Behavioral health is a great example of that. We free up space on the in-person to take care of folks who want to be in person. We made the system more available to families with young kids. I'll blame, I'm a single mom now. My child has not gotten a shot inside of the military health system since my husband passed away. I take him to Giant. That's not a slam. That's a good thing. That's a good thing that my benefit allows me on the weekend to take my child to get his flu shot. And we do it together because he cries when he gets shots. But so I share that last piece because it's not just inside the direct system. We have really, really committed partners in Humana, HealthNet, PSI, our pharmaceutical as well. And we're all about how do we better have a responsive healthcare system, more inclusive, if you will, and not recreating what we had in 2017, because I'm convinced that's not going to help us in what we owe all of you.
Cheryl Carlson, bam.
Yes. And made a badge just so you all know it was kid.
We didn't say you're and that's
I'm not sure who this falls on, but I run a mental health center, behavioral health center here, and I'm having trouble understanding reimbursement rates to TRICARE because of the 40 some odd companies we work with, TRICARE reimburses the lowest amount. Also, if I see a military one-source client, they will pay around $75 an hour for that. TRICARE pays me $51 for non-clinical, for military one-source, and clinical $51. It doesn't make sense to me. Can you say something about that?
Yeah, it's pretty straightforward. The TRICARE reimbursement rates are set by law at Medicare rates. And we do have some latitude to go above, and we certainly have done that. And particularly in the space of mental health, we certainly can put more money to it. But the reimbursement rates start out with Medicare. It's a federal entitlement. And so that's where the reimbursement rates start. Yes, sir.
I just add to that we get reimbursed about $75 from Medicaid, but again, $51 from it.
And you're in the network, correct? Yes. Yep. And so we have 2 network partners, and we negotiate those rates. So the floor starts, and we pay above, but you negotiate those rates with, I'm assuming we're on the East Coast, Humana. Do I have that correct? Right. So I would ask that you hold us accountable and you push fast. But the network providers currently are incentivized, full transparency, to negotiate and at a lower rate. With the next contract, when it's released, it improves on, I call that a perverse incentive, if you ask me, right? It improves on that perverse incentive to not negotiate below the Medicare rate. So Medicare sets the rates, then it negotiated with whoever's in the network, and you all settle in on what that rate is. We have latitude to pay above the rate when it's required. For our behavioral health, our number one challenge is capacity, both in and outside the system, with getting enough patients seen for all the demand, and you don't have that. And again, we could pay above the rate, but that's something I would ask FAST to work with both Humana and HealthNet on the rates that you negotiate with them. And hi, I'm recording. Sorry.
Oh, you still have not allow it. Wait, one text. Okay.
Jealousy is so ugly.
I know. It's very nice. So the people can do. The MCLB Albany has a clinic. It's headquarters out of Jacksonville, Florida. But we have one PCM. And we have, correct me if I'm wrong, just shy of 300 active duty. 355 active duty, not all married, but still many with families there. One PCM, and it is right-hand, left-hand person, just PCS that leave and haven't been replaced. So we have families going out in town that can't find. So the biggest question always on our spouse Facebook page is, who do you use for a pediatrician? And most of them will go out of town. So from where the base is located, and just to get into Albany is 30 minutes. So now we're going out of town. So we're pulling kids out of school to make a doctor's appointment because we don't have pediatricians that will accept TRICARE or just not enough in the area. How do we, when a spouse asks me, what do I do? Because now my students are missing a full day of school, so I can drive. And so pediatricians, I know dentists for that matter. That we don't have dentists that say, get out of here for you. So we're driving all the way over here, an hour and a half, for dentists, doctors, for driving to Thomasville, you name it. We're driving Stillwater, but we're not keeping our kids in school. I do. So one of the things I talked a bit about is the digital front door. First, let me say up front, I'm not going to solve the shortages of healthcare facilities and providers in our country. I need to be honest with all of you on that. You're describing experiences in rural America, and it's now becoming urban challenges where we don't have folks who will take TRICARE because of reimbursement rates. We have less nurses, right? So we have a crisis in healthcare. So let me say that up front as honest context. And so what are we going to do about it? I tossed a little bit on the margins about the digital front door. Conceptually, that's so we can see you. And when we can see you, we can have opportunities. So instead of you getting your care, we're open 24/7 worldwide, and you think about the military health system. Is there a way for you to virtually get that care? And the provider may actually be in Hawaii, right, because of our healthcare system. So internal to the healthcare system, we're working on that. With respect to our managed care support contractors, they're looking at virtual capability because virtual capability helps us mitigate some of the distance that you're describing to make sure that the kids or the patients that have to be seen in person, when they make that hour-and-a-half trip, because I'm not going to pretend that we're going to put hospitals and clinics every one of your neighborhood. We're not going to be able to do that. But when they make that trip is value-added and minimize the number of times you have to make that trip, right? And so we have to evolve our current system of care, which says that you come in between 9 to 5, you come in for a face-to-face, you come in on our time, we do great care and you get in, and then we repeat that. And so I'm pushing hard on us to look at a better way to deliver healthcare, to put some of those tools in your hands, such that when you engage the healthcare system, it brings value. For the isolated locations, I'll give you a different perspective if you allow me. Most primary care providers, when they have an empanelment, the empanelment is somewhere around 1,000. It's 1,000 people. When you look in the United States and you look, because at about 1,000, that's a balance of keeping that provider and that resource busy enough such that they are delivering value in that area versus, and in the military, we have to find the right balance between readiness and the business. So I just described the business. 1,000 is the business. The military health system proposition is we really need to put primary care just about every place we can, even if it's limited. And you described the limited example, right? 300 service members and their families. We're going to put at least our resource there, and then the risk of having our resources, what you're describing, you don't have periods of underlap where the network is supposed to help us to mitigate that. The network is strained. I don't deny that. It's a hint. You're still in the hot seat. And that's why I'm standard. So like, oh, so my question, I know that it hasn't brought to Congress. I'm trying to get some insight if that's there. And I'll see, I have a soon-to-be senior college student who will be about 8 months kicked off of TRICARE. And I know that they were talking about trying to meet the private sector of children, military dependents, to meet the private sector of being on healthcare coverage until they're 46. Yes. I was just wondering if anybody had on that. I don't just fill in also with anything I'm in doubt. Yes. I did that for a young adult.
There's a Congress that hasn't gotten enough traction. So, and it's been there just 3 years or.
Yeah, I don't have any. Yeah, that's the update, unfortunately, is the thing on country young adult. And if your child is in college school, not enrolls there, state age 40, a certificate from the college for getting up full-time enrollment, and they give you just call you in the same thing. So,
I'm going to give you a break with General Coughlin. This question is for Mr. Klipstein, actually. You talked about the quality of life task force and PCS moves for the military community. I'm the new MWR director for Fort Moore. Been here about 5 months, so I'm PCS'd in from Fort Sill. And as part of my PCS move as a civilian, I too incurred a huge tax burden. So you talked about, trying to alleviate some of the cost of the PCS move for the military family. I too am a military community member. Are civilians part of that discussion that you are championing as part of that task force?
The answer is yes. We brought the issue to bear a couple of times with the Department of Defense, but as you know, and it's a congressional requirement that the entitlements that civilians have for when they PCS is taxed. And so there are offsets that the department provides, but it doesn't completely offset. And I'm well aware that I've got friends of mine who have made ECS moves who've incurred $10,000, $12,000, $14,000 tax bills as part of their transfer from one location to another. So each year we continue to ask for reconsideration, but it's not just the Department of Defense, it's really the government-wide where that sits. But we continue to ask for it, and we continue to push it with the DOD. I'm going to look at my DOD partner. I don't want to put her on the spot. No, okay. All right. But we do, with our congressional liaison, continue to push that. So the answer is yes, we're working on it, but I don't have a great answer for you.
Okay, we've got time for one more question, sir. Go ahead.
Good morning, ladies and gentlemen. My name is Colin Malley. I'm proud to be the Fort Moore Garrison Commander. I have a question about BAH and specifically about BAH reform. Acknowledging that BAH is a DOD managed system, so Fort Moore has experienced a bit of a BAH inequity over the last 6 to 8 years. We had a great spike last year, going up to double digits, 10 or 12%. And there are some parts of the system, specifically the anchor points and whatnot, that aren't always transparent. We're trying to continue to advocate, but I just as it's in talk about potentially updating that system and what that looks like moving forward. So appreciate your thoughts on that. Sorry.
Thanks for the question. Yeah, BH, DOD is not a marketing firm. So, first, I would like to encourage everybody. You can actually search this. It's BH primer. It's actually a document that's published by OECD PNR. It has all the information on BEH. So BEH, by design, before 2000, wasn't actually designed to pay for all your housing. So initially, 20%, the expectation was 20% service members supposed to pay for out-of-pocket. So in 2000, that changed. SecDef said, okay, I think we got to do something about that to make sure we take care of people. And the goal had always been zero out-of-pocket, right? Zero out-of-pocket. Now, there's an effort right now to get to that point. Right now, we're about 95%, I think. And the expectation is 5%. And MOA is actually supporting that, through legislation. So that's the end game, right? Zero out of pocket for everybody. The other thing to know about BEH is that it's based on rental, right? It's based on rental, right? Your BEH is based on location, right? Your pay grade, which is income, right? The expectation, the median in the market for a rental property, right? Now, if you buy a house, that's a completely different story. It depends on the variables of, how big the house is. And by the way, if you own a house, you also incur additional costs, right? Maintenance of the house and all the things that comes with owning a house. So all those things are need to be considered when you think about BEH. So again, the goal is zero out of pocket. I think we're close, 95%. I think we're gonna try and push that. And this is not just Army. This is of course across the services. But I would encourage everybody to download that document, BEH Primer. They'll give you so much information. And lastly, about BEH, everything is a process, especially in the Pentagon. Last year, the prices of housing had accelerated. And, the way we do business and the way we do things in terms of timeline on adjusting BEH, it's not as agile as the market. So there's a lag in, making sure the BEH is comparable. So with that, I'm going to pass it over to Dan.
So a lot of work being done is, again, part of our quality of life task force and the efforts that we're looking at to work with OSD to become more agile with the BAH rates and the ability to move quicker or reassess more frequently. I'm not sure you come. Okay. All right. But, as Joe McRae said, it's something we're continuing to work on. We recognize, and it's a priority for the department as we look to trying to make improve the ability of our soldiers and families to get quality housing wherever they go.
Thank you. Sir, would you mind handing the mic? One more question. I lied. This is the last one.
Not a question. I just want to make a comment. I'm a Gold Star mother, and I'm representing Gold Star mothers here today. My daughter was 15 years in the military. She moved to 5 different bases, 1 overseas. And I'd like to add to that I stayed with her quite an awful lot. I understand what you're saying about zero payout for BAH, but I also want to recognize that if you look at our bases and if you look at the outside communities surrounding those bases, a lot of those communities were built in the 1970s, 1980s when Vietnam veterans returned from service. Those houses are now, 30, 40 years old? My daughter had to stay in a HUD development in order to be able to meet half of her pay from BAH. So BAH paid only half of her rent in a HUD development. And when I drove onto post here today, I've been here a couple of times now, I noticed, as well as 2 of the other places that she stayed, that the areas immediately outside post are not safe. And so BAH is based on, as I think she told me, a perimeter of so much housing directly surrounding that base. And I think anybody that's military here would agree that you don't stay close to base. you move further out because it's not safe to be here. And the places are dilapidated. I know when I came just up here to the museum this direction versus on post, how dilapidated the area was. So maybe it's a zero amount, but it's still not meeting the quality of housing that we need for our soldiers. Yes, we've had a very significant increase in housing costs. It's just in the last year, and COVID has certainly contributed to that. But she complained about BAH for 10 years. So I just wanted to speak to the fact that when you're looking at a soldier and a soldier's family and they're looking at schools and quality schools for their family members, we have to consider that when we consider the amount of BAH that's being given.
With that, ma'am, thank you for that. We are going to wrap up this conversation. I just want to call out a couple of high points. Military life is about the ecosystem of support, and that's not just on DoD. That is on everyone in this room. That is on our community partners to create that ecosystem of support. We've heard of some, excellent advancements in healthcare, and the Military Family Policy Office that Ms. Patty Barron works at. They have some amazing programs that really go to the heart of what our military families are frustrated about. So I encourage you, I empower all of you to take some knowledge here, corner these folks during the break, get the information that you need, and then pay it forward, share it. We have to do a better job at getting the word out, because if we have all of these awesome programs going around employment and fellowships and healthcare, if they're not getting used, they're going to be no good to us in 3 years. So we need to do our part to help promote them on behalf of DoD, because again, they're not a marketing firm. We can't be everything. But I appreciate everybody's questions. The rest of the day, we are going to have some really interactive panels. We're going to take a 10-minute break right now, and we're going to come back for another panel and some more community engagement. So thank you all for your time.